Dear friends, I think we can start. It is time. This is our 17 online symposia on WFNS with Education Committee, and I'm very grateful to be with you. That discussion on the management of vestibular Schwannomas. And we have very distinguished guests to speak. And I give the words to Dr. Roberto Leal de Silveira and Sabino Luzzi for moderating the session. Thank you all for participating.
Yes, good day to everyone. Let's work together, Sabino, and start it. It's going to be, the anatomy, the three modalities of treatment, and complication. But also, let's start with the anatomy, by Professor Maximiliano. Go ahead, Maximiliano.
Good morning. Thank you. I am not professor. I am a simple man.
Okay.
Sorry. Okay. No. Thank you. Thank you for the presentation. I will share my screen. Yes. Okay, you can see the screen?
Yes.
Yeah.
Okay.
Max, you should unmute yourself because you are muted. Can you hear me, Max?
Yeah, there. Sorry.
Okay,
now
perfect.
You can hear me now.
Yeah.
Okay. Again, thank you for the invitation. I am glad to be here. I will try to be short in this presentation. We will talk about the Cerebello-pontine angle and the anatomy, of course, the implication and the utility of the anatomy of this beautiful region in the skull base for the use, of course, in the surgery, in neurosurgery, like everybody knows. Thank you again for this invitation. So the CP angle is a very interesting area. We can define the CP angle in this beautiful view of the brainstem in the frontal view by the structures we can find in this area, these limits. For example, we can see here the Cerebello-pontine fissure with superior limb in the red. You can see in the red line the inferior limb and the petrosal fissure in the anterior face of the cerebello-angle-pontine junction. So in this view, we can see the superior part of the cerebello-pontine structures at the level of the cerebellum in the anterior petrosal face. Even in yellow, we can see the inferior face, the inferior portion. This part is, of course, in front to the petrosal bone. So here we can find different structures. Neurovascular structure, we will see in the next slide. The most important structure here from the top to down, for example, we can see the 5 cranial nerve, we can see the 6 cranial nerve in the medial limit of this area over the pons. Of course, in the lower part, we can see the 7 and 8 cranial nerve, and at the level of the medulla oblongata, 9, 10, and 11 cranial nerve. Even in this picture, at the level of the leaf in the anterior sulcus, between the olive and the corticospinal tract, we can see the 12th cranial nerve. So this description is crucial to understand the position of these important structures, not just the neurovascular, even part of the pons, part of the medulla oblongata. We can divide this beautiful area in three areas in self: the superior portion, the medial portion or complex, and the inferior complex, like we'll see in a few minutes. So this superior view with the skull base and the cerebellum inside is interesting because we can see and we can define what is the cerebellar angle area. So we can put the cerebellum inside in the skull base to understand which part of the occipital bone have implication in this anatomical area, even which part of the temporal bone, the petrosal bone, have the implication to define the CP angle itself. In the right side, we can see the different structures like occipital bone in the frontal view, the occipital bone in the lateral view, and even in the last picture, we can see the foramen magnum, the clivus, petroclival fissure, internal acoustic meatus, and, for example, in the lower part, the jugular foramen. These structures, bone structures, bone details are crucial when we try to understand the different position of the cranial nerves, the vascular structures, and the CP. This is the CP angle, like we know. This is the schematic description of the Professor Roton. Of course, everybody knows this, the complex of the tree, the superior or upper neurovascular complex with the cerebello-mesencephalic fissure, the junction between the pons and the mesencephalic portion of the brainstem, the junction between the pons and the medulla oblongata. Of course, we have many structures inside, like superior cerebral artery in the upper complex, the midbrain, like we talked before, the cranial nerves 3, 4, 5, cerebello-mesencephalic fissure, like I said before, superior cerebral peduncle, and the temporal face of the cerebellum. We will put focus in this upper part, in this upper complex, and in a few minutes, we describe the middle and the lower complex. This beautiful design of the rules of the tree is crucial to understand the CP angle and the utility of the anatomy for neurosurgery. This is the dissection of the trigeminal nerve. We put focus in the upper part, in the upper complex, because it's crucial to understand the distribution and position of the superior cerebral artery below of the forecranial nerve and the division of the superior cerebral artery in two branches. In general, the lower part or the inferior branch after the division of the superior cerebral artery is the artery who made the compression with the trigeminal nerve when we have the problem, of course, the trigeminal neuralgia, and we can see there the division in between the motor and sensory root of the trigeminal nerve, in this case, burning or in the superior border of the middle cerebral peduncle. Even we can see the lower part of this structure, but we will describe in a few minutes too. In the right side, we can see the superior view of this beautiful anatomy, where we can see the distribution and the position of the 5 cranial nerve coming from the posterior fossa to the middle fossa. Even in the upper part, the 4 cranial nerve and the relationship with the free border of the tentorial area. In this case, the 5 cranial nerve is hidden behind of the dura mater of the middle fossa. In this section, we can see the distribution in 3 parts. We put one circle in the superior complex. We will put the second circle in the middle complex between the ICA and, in this case, 7 and 8 cranial nerve in the CP angle, and the lower part at the position of the pica, and the relationship of this artery with the inferior complex with the lower cranial nerve. This beautiful anatomy is very interesting to understand the distribution and the relationship in the CP angle of the 3 parts of the 3 components of the neurovascular complex between the superior cerebellar artery and the 5 cranial nerve, between the ICA with the 7 and 8 cranial nerve in the CP angle itself, and the lower cranial nerve with the pica. So we put focus in the 5 cranial nerve and the relationship with the superior cerebellar artery. Like I said before, the superior cerebellar artery is crucial in the pathway when the superior cerebellar artery is divided into branches in the lateral surface of the brainstem. The inferior branch in general make a touch or make a pressure over the 5 cranial nerve, and this is the problem in the decompression in the trigeminal neuralgia. So the superior cerebellar artery run around of the midbrain, reaching the posterior cerebral cerebello-mesencephalic fissure. In the right side, we can describe the position of the superior cerebellar artery. Here we see touching or making depression over the 5 cranial nerve in the cisternal space, and even we can see the 3 division of the 5 cranial nerve. We made a hole inside in the Gasserian gangle in order to describe the motor roof of the trigeminal nerve. So this is the lateral view. We put some spatula in order to describe the cisternal area between the mesencephalic portion and the cerebello-mesencephalic fissure. In this case, we put focus in the relationship of the superior cerebellar artery with the 5 cranial nerve, like we see in this area. And if we put focus inside, we can see the distribution of this artery over the 5 cranial nerves. So the superior complex, the most important is to understand the different points where the superior cerebellar artery, in this case, can be make a pressure over the 5 cranial nerve in order to make the trigeminal neuralgia. Even we can see the distribution and relationship of the 5 cranial nerve with the 7 cranial nerve. In itself, the 7 cranial nerve is part of the middle complex. Even in the lower part, the rhomboidal lip, the flocculus, and the relationship with the lower cranial nerve with the inferior part, like the pica. Here we see the compression, here the middle. And this beautiful view is very useful to understand, for example, in the right side, how is the distribution of the superior cerebellar artery, and sometimes the loops. The superior cerebellar artery in most of the times make a division in 2 branches, but in some percent, the artery is continued with just one vessel, no branches. But in this case, in this dissection, it's very interesting to see how is the loop of the superior cerebellar artery to make a compression over the trigeminal nerve. Here we see, even in this reconstruction schematic view, we try to describe in sometimes the basilar artery make like a curve in the dolicho-basilar disposition to make a compression over the 5 cranial nerve. This is the one variety of the basilar compression. So this schematic and very useful picture of the Professor Roberto's book is to understand the different position of the spatula in order to describe the superior complex, in order to find the middle complex, and in order to find the inferior complex. This spatula is when we put the spatula in order to find, in order to push a little bit to medial, in this case, of course, the cerebellum, is to understand which is the position of this different complex, neurovascular complex. Here is the general view to understand the superior complex in the left dissection. In the left picture, we see in the deep the 5 cranial nerve. We see in the central part of the picture with the dissector, the 7 cranial nerve and the 8 cranial nerve. In this case, we don't divide the nerves, it's just to see the distribution and the relationship with the ICA and flocculus and rhomboidal lip in the middle size of this description. In the lower part of this anatomy of this picture, we see the lower cranial nerves and the relationship with the pica. Even we can see the 12 in cranial nerve over the vertebral artery in the inferior and deep portion of this dissection. If we move the vision in the central portion of this picture, we drill the condyle in order to find the hypoglossal channel and the distribution and direction of this cranial nerve inside. In the right side, we can see in the upper part of the screen the relationship of the 5 cranial nerve coming from the middle cerebral peduncle and the root of this cranial nerve. The sensorial root is pushed by the dissector, and in the deep we can see the motor root. In the upper part, the 4 cranial nerve. In the lower part, between the bone and the surface, the petrosal surface of the cerebellum, we see the 7 and 8 cranial nerve and the position of the ICA. In the more lower part of this screen, in the inferior picture, we see from back in the right side, the lower cranial nerve and the 11 and the relationship with the pica and the 12 cranial nerve. Even we need to say the compression of these structures like a 5 cranial nerve, for example, can be made by vessels like veins, not just artery. That's the reason why it's important to understand some special topic about this. In this case, in the frontal view, in the big screen, we can see the Cerebello-pontine vein. This vein is very important to understand because sometimes run in the lateral surface of the 5 cranial nerve and can be the reason why, or the origin, sorry, of the trigeminal neuralgia. Even in B, we can see the middle cerebral peduncle vein. In this case, is a little bit bigger. So this vein runs in the lower part or medially to the 5 cranial nerve. Sometimes these 2 veins can be the reason by to make the trigeminal neuralgia. In the opposite side, in the right side of the screen, we can see the vein of the Cerebello-pontine fissure. This is another vein who made the trigeminal neuralgia. Here in the middle complex, now we put focus in the central portion of this CP angle. We find the 5 cranial nerve, we find, of course, the 7 and 8 cranial nerve and the relationship in the deep, even with the 6 cranial nerve. The petrosal surface of the cerebellum is in front of the petrosal bone, but the focus in this case is between the petrosal surface of the cerebellum and the bone and the internal acoustic meatus. In the internal acoustic meatus, we can see the position of the 7 cranial nerve. In this case, here, the relationship with the ICA, superior and inferior vestibular nerve, and the cochlear. Here, the 6 cranial nerve. Now, in the delicate dissection, we can see here the 7 cranial nerve, superior vestibular. Here we can see all the elements inside. Now, in this beautiful view, we can understand the position of the superior complex 5 cranial nerve, the relationship with the rhomboidal lip and the 7 and 8 cranial nerve, the lower cranial nerve, and with the relation with the jugular foramen. Even in the lower part, 11, 12 running over the vertebral artery, and even with the drilling of the condyle, we can see the direction and the shape of the 12 cranial nerve inside in the hypoglossal channel. About the position in this case, this is the schematic view of the Roton book. Of course, the retrosigmoid approach is the most useful in my opinion. We can do in this position the approach to the CP angle, even in semi-sitting position. This is some picture of one patient. We use this position most of the time in our hospital. Some of us, we use even the semi-sitting position, like I said before, but sometimes we prefer, in the most of the cases, this approach. In this case, we put this schematic illustration of the Professor Roton book to understand the point of the compression of the middle complex, in this case, the facial nerve, to describe or to understand the hemifacial spasm. In the left side, we can see the ICA under the compression over the 7 cranial nerve. Sometimes the ICA is longer and make a loops, and they loops, loops can be pushed or can be the reason for the hemifacial spasm. So in the B, in the lateral side of this schematic point, we can see even the vertebral artery. We see in the circle, in the yellow cycle, the compression of the vertebral artery over the 7 and 8 cranial nerve. But in the blue cycle, we can understand one variety or variability of the pica. In this case, the pica is the reason why the 7 cranial nerve is pushed. Here, the lower complex, the lower cranial nerves, we see in the first slide, in this case A, the position of the 9, 10, and 11 cranial nerve. The 9, 10, and 11 at the level of the jugular foramen. This is a very important structure to understand, and the distribution, the root of the 12 cranial nerve over the surface or dorsally with the vertebral artery. In B, we see a closer view and the distribution of this root over the vertebral artery. In the C picture, we see the distribution, very, very delicate distribution of the 9, 10, and 11 root of these lower cranial nerves. These beautiful view are very important because in this case, we understand the relationship with the neurovascular lower complex and some compression like neuralgias over this lower cranial nerve, like everybody knows. This area, CP angle for tumors, like the rest of the professor we will talk in a few minutes, are very important to describe this anatomy because it's very useful in case we need to approach this area for not just neuralgia, even, of course, Schwannomas, different pathology, even when we need to access to the brainstem, like a different level of the brainstem. In this case, the lesion in the upper cerebello-pontine angle might be exposed in the interval in the window between the superior complex and, of course, 5 cranial nerve. Even we have the second window between the 5 cranial nerve and the 7 and 8 cranial nerve, and the most lower part, the most in my opinion, the most little window is between the 7th cranial nerve and the upper part of the lower cranial nerve. These 3 windows can be used by the neurosurgeon in order to access to the different aspect of this CP angle for the reason to remove some tumors or some pathologies, of course. So this is the step by step. In this case, in the lateral side of the screen, we see the incision, the curved incision. We prefer this incision. Sometimes we use, I am honest, straight line incision, but most of the case we use this. In B, we see the dissection step by step. It's important to understand the point where we start the craniotomy, the asterion like a landmark, and the exposition of the transversal sinus, the sigmoid sinus, and opening the dura mater, we can expose in C the upper complex. In D, we can expose the middle complex, and in the E view, in the E picture, we can see the lower complex like we described before. This is to understand the dissection of the CP angle. I put just this short video just to see and describe what is the utility of the laboratory. I know many people here, like Professor Vizcaya, have laboratory in her hospital. And many of us, we believe this discipline is very useful for the neurosurgeons, because we can understand in this way the best anatomy, the three-dimensional distribution of the different elements, not just for the CP angle, even for all the structure in the skull base. So I try to simulate one surgery, very delicate. Of course, everybody can understand is the cadaveric dissection, so the tissues are very straight and very strong, attached to the bone. So sometimes it's difficult to be very delicate, but we try to recreate one sequence of the surgery. Like I said before, many people can take the decision to do one strike, a very short incision. The incision here is bigger, because if not, it's impossible to do the craniotomy, because, like I said before, this is a cadaveric dissection. So in order to respect the time, I will try to go a little bit more faster, but this is the exposition with the relationship with the occipital artery, like we see, with the different layers of the muscles. You know, we can describe this when we do dissection for lateral approach. This is not necessary. It's just anatomical dissection, didactic. Now we can expose the asterion. The asterion is the very important landmark. Everybody knows this landmark. In order to start the craniotomy, we use the drill to do one craniotomy and expose the dura mater. The key point, of course, is the exposition of the junction between the transversal and sigmoid sinus, and opening the dura mater, we can expose the different neurovascular complex, of course, with the spatula, like a schematic view of the Professor Roton I showed before, in the upper part, in the tentorial surface, or even if we put the spatula at the level of the petrosal surface. If we put the spatula in the lower part, we can expose the lower cranial nerves. This is the general view. And like I said before, the application of the anatomy in the real life is crucial to understand this complex anatomy. So,
Max, we are sorry, but we are almost at 30 minutes, no?
Okay, we finished now, doctor. This is the last video. I will finish with this. I will go fast. This is the dissection of different components, the vestibulocochlear nerve, facial nerve. We see all the elements there. So this is the full view to finish and to understand the CP angle. So this was just a little description of the CP angle and all the elements inside. So thank you very much for the attention. I hope can be very useful for us.
Thank you.
Thank
No,
you.
beautiful, beautiful image. But Sabino, we have to move ahead, no?
Yeah, sure. We have to move.